Good morning, everybody. Good afternoon to those of you who are in the Northern Hemisphere. Today is one of the Health Services Research Association's monthly webinars, and we're very pleased to introduce an international speaker. Before we do, I'd just like to introduce myself. My name is Rachel Morton, and I'm the President of Health Services Research Association of Australia and New Zealand, and we provide a number of forums for education and training in health services research, including a monthly webinar series. And our next webinar is going to focus on alternate career paths for health services researchers, and that's going to be on Monday the 29th of April. The other main event for our association is the conference, which is on every 2 years, and you can see on your screen the flyer for the conference, which is going to be in Auckland this year from the 4th to the 6th of December, and individual abstracts open in a couple of weeks. So please consider the work that you're doing in this area for submission to this conference. I'd now like to introduce Dr. Heather Brown. Heather is a senior lecturer in health economics at Newcastle University in the UK, and she's going to be talking to us today about some technical approaches, statistical techniques for evaluating public health interventions, specifically the introduction of minimum pricing of alcohol in Scotland, and also sugar-sweetened beverage taxes. The way the webinar will work is that Heather's going to present for around 45 minutes, and you'll have the opportunity to have your questions read out to her at the end, and the way you do that is by using the Q&A link at the bottom of your screen. So thank you very much, Heather.
Hello everyone, and thank you. I've never presented this way, so hopefully it'll be okay and I won't start to speak too quickly. So this is a brief, I'm trying to, hold on, sorry, the slides are not turning. Okay, there we go. Okay, so this is an abridged version of a CPD course that I've developed and has so far been offered once of teaching, I guess, public health practitioners how to, some common policy evaluation techniques. And as Rachel said, we're going to be looking at 2 case studies. So one of them is introduction of the minimum pricing of alcohol in Scotland, and one way that you would be able to evaluate that type of legislation. Another is how you'd evaluate a sugar-sweetened beverage tax. Okay, so both of the techniques we're going to discuss today are before-after study designs. So in many cases, because of how policies are implemented, public health interventions policies are evaluated retrospectively without a clearly defined control and treatment group, and also the nature of many policies. So both minimum pricing of alcohol and sugar-sweetened beverage taxes are universal policies. So in a sense, you don't have a control or treatment group to evaluate. So it makes it slightly more difficult to use kind of a randomized control trial type study design. And because of this, it makes it difficult to establish causality, because it's not clear if any change in behavior is a result of the intervention or something else. But before-after study designs are useful techniques to try and establish if a policy intervention has had an impact on health behavior or health outcomes. Okay, so the first technique we're going to discuss is something called difference in difference. So why do we want to use this technique? So if you were to simply do a pre-post study, the results may be biased because of unobserved factors that impact on the outcome of interest. That would be the health behavior or outcome, and may also change with the intervention. So some examples would be kind of, if you were to look at, say, the minimum pricing of alcohol, some unobserved factors might be social norms around drinking, propensity to drink, and it could also be sort of unobserved factors such as kind of other public health campaigns that would be going on alongside this intervention. and if these unobserved differences also impact on what you're going to use as your control group. So that would be some things, as I just mentioned, such as propensity to drink alcohol, social norms around drinking, or other public health policies. Then double differencing can remove some of the bias on the coefficients from these outside factors so that you can isolate the impact of the treatment effect, which is the intervention, in this case, minimum pricing of alcohol. So that allows you to estimate a causal relationship so you can see how minimum pricing of alcohol has impacted on, say, alcohol consumption. Okay, so what types of data can be used? So you can use repeated cross-sections of data. So a cross-section of data is a survey that's asked to individuals every year. And there's some surveys that are asked to different individuals every year, or the same individuals for, say, 2 years. And some examples of these are the Health Survey of England and the Scottish Health Survey. Or you could also use longitudinal data. And some longitudinal data would be something like the Household Income Labour Dynamics of Australia, otherwise known as the HILDA, Building a New Life in Australia, which is a relatively new data set looking at asylum seekers and refugees, and Growing Up in Australia, which is a data set looking at children. And you need to have data on 2 groups. So it would be those who are directly impacted by the policy intervention. So if you had something that was implemented, I guess, in an Australian context, it would be implemented in some states, but not in all states. So therefore, you also then need a group that's not been impacted by the policy intervention. And you need data on both groups for at least one period before the policy intervention and one period after the policy or intervention. And I guess it's important to note that if you were to use a repeated cross-section, then you'd be able to control for population characteristics over time, but not individual characteristics over time. You need longitudinal data to be able to control for individual characteristics over time. But then if you can use data, longitudinal data, so on the same individuals over time, that means you can control for time constant unobserved differences between people who have been directly impacted by the intervention and those who have not. And as I said, if you use repeated cross-section, then you can control for population characteristics that would be similar in the treatment group and control group. Okay. So then, as I said, for difference in difference, a case study we're going to use is evaluation of minimum pricing of alcohol in Scotland. So in this case, our outcome of interest is mean alcohol consumption. So we want to see if the legislation has had any impact on the mean alcohol consumption in the Scottish population. And the control group we use are individuals living in England, because legislation was only implemented in Scotland. And the treatment group is we use individuals living in Scotland who have been affected by the legislation. So some unobserved factors that might bias the results, meaning we can't just use a simple data on pre-post only, is that there are seasonal factors that might impact on the opportunities to drink, such as people drinking different amounts of alcohol in the summer or the winter. Or as I had mentioned earlier, there could be some sort of public health information campaign which might have impacted on how much people drink. And this could have been in only Scotland, only England, or it could be in both places. Okay, so this is a sort of graph of mean alcohol consumption before and after the implementation of minimum pricing of alcohol. And it's important to note that this is just a hypothetical graph, that this is not using actual data, just to show you kind of what you would need to do if you were using this technique. So the control group is individuals living in England. So we could see what their alcohol consumption was before the introduction of minimum pricing in alcohol and after. The treatment group are those living in Scotland. And the counterfactual, which is the blue dotted line, is the alcohol consumption of those living in Scotland if there was no legislation. So that's kind of what we're trying to estimate. So we're trying to see how alcohol consumption has changed from the legislation. So effectively what we're doing is looking at the difference between the counterfactual and the treatment. That's what we want to estimate. So that if you were to use this method yourself, what you want to do is you'd want to take your data and you'd want to plot it so you can see the trends for your control group and your treatment group to look at how similar they are. And then what you want to kind of do in the estimation is to figure out what the counterfactual would be. So what alcohol consumption would be without the introduction of policy or intervention or legislation, whatever you're looking at. Okay, so then how do we estimate this? So here is a sample equation. So in this case, we have the outcome variable, which is Y, is mean weekly alcohol consumption, and this could be, say, in grams. And then you have beta 0, which is the constant, and then you have beta 1 and dB, and dB captures the potential differences between the control and treatment group pre-intervention. So that is such things as I've mentioned earlier, the propensity to drink alcohol, social norms around drinking, anything like that. And lambda 1 is a coefficient of interest as it represents D2 times dP. And D2 is the intervention. So that's just a dummy that equals 1 if it's post-intervention and equals 0 if it's pre-intervention. And so then what we're actually estimating is so the difference in mean alcohol consumption for the treatment group, post-intervention minus pre-intervention, so it's mean alcohol consumption, which is a line on top, and that is subtracted from the control group post-intervention minus control group pre-intervention to give you, as you had in the previous slide, kind of this counterfactual minus treatment line. Okay, so basically, if you have even modest, so you don't need extremely large sample size in each of the 4 groups, it's relatively straightforward and robust to use a variety of time periods or different control and treatment groups to estimate using this framework. Okay, but after you would estimate the equation on the slide, it's important to do a few checks to make sure that you have been able to estimate this counterfactual and causal relationship from the intervention onto your health outcome or behavior. So one robustness check that you could possibly do is to include 2 control groups. So that means you can include, in our example, because there's 4 different sort of areas in the UK where they have differences in legislation, is that you include a control group from England and also one from Wales. So in this case, that is called a difference, 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 or triple difference estimator. So that also then could kind of double check your assumptions on the time constant unobserved factors such as propensity to drink, social norms around drinking that might have been biasing your coefficient or your ability to estimate how much the intervention has impacted on alcohol consumption over time. And so this estimation technique, the triple difference estimator, controls for time trend changes in alcohol consumption by using not just 1 but 2 control groups to kind of see how if there's any other factors that might have been biasing your coefficient. And both the standard difference in difference and the triple difference approach can be employed to multiple time periods by including a full set of time dummies in the estimation model. So it means you can use a number of periods pre and post intervention to try and determine how the intervention or policy change has impacted on your outcome of interest. And another important thing to do is to use placebo checks. So that's where you estimate the equation on the previous slide, again, using different time periods. So you looking at it all say pre-intervention to make sure that you're not finding the same effect, because then if you were, it would mean that something else was driving your findings and you weren't actually estimating the counterfactual. So you want to look at a period when the intervention was not in place, because then there would be some other trends in alcohol consumption that might be explaining the findings rather than minimum pricing of alcohol impacting on bean consumption. Okay, so things to keep in mind. When you're defining your control and treatment group, this is often usually defined by geography and time period. As we said in our example, that's we use geography because policy was implemented in Scotland, so you can compare people in Scotland and England. But you could also say if a certain policy was only available to, say, people from lower socioeconomic backgrounds, then you could define your groups by socioeconomic status and geography. Or you could do something, if it was only available to women or men, you could look at time, or if it was only available to older people or younger people, then you could look at gender, so you could look at age, gender, geography, or time. But it is key to keep in mind that differencing needs to be a credible way to deal with non-group equivalents. So what does this mean is that what you have to think is impacting on your ability to estimate the relationship between the intervention and your health outcome is some time constant unobserved factors, such as we mentioned, propensity to drink. If it's something that varies over time, then this approach will not be able to control for that type of bias. And the other thing to keep in mind is that time constant variables, so those are variables that don't change over time. So if you could think of, I guess, an obvious one would be gender is unlikely to change over time, that if you were to include these as controls in your model, that they would be differenced out, so you would not be able to find an effect by gender. So if you're interested in looking at differences by gender, what you would need to do is you would need to split your sample by gender. Okay. And then the next thing that you need to think about when estimating this model is bootstrapping. So this is as well to make sure that you're not leaning to type 1 or type 2 bias. So that means incorrectly rejecting your null hypothesis or accepting your null hypothesis. So kind of determining if there's a statistically significant relationship. Because using the first difference approach, your standard errors might be biased. That's why bootstrapping would be a sensible thing to do. So as it says here, that if you were to use this equation without bootstrapping your standard errors, your standard errors might be biased downwards. So what bootstrapping does is estimate a model for a specific number of repetitions using samples of the data frame. So that means it's using a certain number of observations. It does not necessarily draw from the same observations, as it allows for random sampling with replacement. So that means if you were to estimate the model, again, with bootstrapping without specifying a seed, it might be taking it from different observations in the sample. So the results would be potentially slightly different. So then what bootstrapping does is for each repetition, the main analysis is repeated on the sample data and the estimates are stored. And once finished, the standard errors are calculated by taking the standard deviation from the stored model estimates. Okay, so then I guess the other thing to keep in mind is cluster versus individual bootstrapping. So you have cluster bootstrapping, which draws from a cluster of units rather than individual units. So this would be what you'd want to do if you, say, we're looking at geographical differences. So you might want to draw your cluster from, say, a local area rather than doing it from individuals. Because if you were to draw, say you had 1,200 individuals in 20 different local areas, if you were to do a standard bootstrap, it would just draw from say 1,000 observations from the 1,200. So you might be oversampling some people in certain local areas, because it wouldn't necessarily do it across all. But so you could basically then say that you wanted to take from the 20 local areas to make it representative of the whole sample that you have. So it would take from the 20 areas a certain number of individuals to make sure that it was recognizing the fact that your sample was clustered by these local areas. And then the final type of bootstrapping is block bootstrapping, and that the data is divided into several blocks, which is sensitive to choice of block. And so the optimal block choice depends on the sample size. And that's similar to cluster bootstrapping. Okay, and then finally, the last thing to keep in mind is this is dependent upon the policy intervention that you're evaluating, is this thing called Ashenfelter's dip. So potentially, if people know that the intervention is coming, they may change their behavior before the intervention. So this would then impact if you, say, were to use data 1 year pre-policy and 1 year post-policy. If people had already changed their behavior in the 1 year pre-policy, you might not fully estimate the impact of the intervention, because the pre-policy data would be biased. So, for example, if there was a policy that people self-selected into, in many cases, say a training program or say a smoking cessation program, then people self-select into the program, which would impact on who's in the intervention group. And then, as I mentioned, a pre-treatment dip will create bias. So to test if this is the case, depending on the type of evaluation or policy that intervention or policy that you're evaluating, is that you can use different leads of treatment rather than lags of treatment. So you can use, if you have the available data, say 2 years before the policy or intervention was implemented, to see how this impacts on your results using 1 year pre-policy. So the null hypothesis is that you have no treatment effects, and then you can inspect the coefficients on the leads and plot the coefficients and confidence intervals leading up to and after the onset of treatment, and compute an S statistic testing the null hypothesis that the leading coefficients are jointly equal to 0. So that's the way to see if the time up to the introduction of the intervention, if that has any impact on people's behavior before the actual intervention is implemented. You want to make sure that that is not biasing your results, because you will underestimate the impact of the policy or intervention if it is. Okay, so that is a very, very quick and brief overview of difference in difference technique. And now we're going to move on to another statistical technique that uses a before-after study design, which is called interrupted time series. Okay, so what is interrupted time series? And so it is a method to retrospectively analyze public health interventions. And it's best suited to population-level health outcomes over a defined time period. So what does it mean by population health outcomes? Will be something, as in this case, we're going to look at dental caries in children. So it's the overall number of dental caries. We could look at something, say, kind of obesity rates in the population. Or I have some other examples below. So on this slide, so kind of a change in the doctor reimbursement system where doctors receive a payment bonus for targeting specific conditions. So in this case, you could look at, say, number of people who have foot referrals from diabetes care, could look at number of people with hypertension rates, and smoking cessation, and as well as we're going to use an example, we can look at the introduction of a new policy such as a sugar tax. Okay, so when would you use this approach? So similar to the difference in difference, you need a clear distinction of pre and post intervention period. And I guess unlike difference in difference, because as we just talked about with the Ashenfeld dip, you can control for using difference in difference potential, I guess, people anticipation effects of the intervention, where with interrupted time series, you cannot control for anticipation effects in the same sort of way using this methodology. But the outcome of interest, so that is a health behavior or outcome that you want to look at to see if the intervention has had any impact on, can be either binary, so that means it can be a 0-1, so that would be something as, say, if an individual is obese or not. It can be continuous, so that is similar to the example we're going to use in this, which is number of dental caries in children, or it can be count data. That's something we have, say, 1, 2, 3, 4, 5. And interrupted time series works best with short-term outcomes that are likely to change relatively quickly after the introduction of policy, rather than longer-term outcomes. So that would be something like a longer-term outcome which you wouldn't want to use with this, is say if you were to look at liver disease after a change in minimum pricing, you think that that would be something that would happen much longer after the introduction, after people change their alcohol consumption, than in the short term. So what types of data can be used for interrupted time series? So you can use a time series. It's a continuous sequence of observations in a population taken repeatedly and usually at equal intervals. So you need to have data that covers a sufficient length of time before change in policy and after the change in policy. And it can be either repeated cross-sections or longitudinal data. So the span of data needed is needed to be able to establish a trend. So you have to be able to look at the rates before the intervention period and rates after the intervention period to see if there is any difference in mean rates before the introduction of the policy and after the introduction of the policy. So basically you're looking at if pretty much what this method does is look at if there's a change in trends from the policy or intervention. So how do you estimate this type of model? So the basic model is estimated using a regression-based model, such as a linear regression that is used for continuous data, a logistic regression, which can be used for binary data, or Poisson regression, which is used for count data. The first basic model estimator would include 3 variables. So you need the pre-intervention slope, the change in the trend of the health outcome behavior at the intervention points, and then the change in slope between pre and post intervention. So that is kind of, if you want to think about it visually, going back is sort of would be, you need the slopes of the treatment, control, the kind of looking, you don't need the control here, sorry. So again, the treatment and counterfactuals. We want to look at the slopes pre and post intervention in a sense. And I'm going back where we are. Okay, so that the basic model with 3 variables would be a starting point. But then to make your results more robust, you could also include additional controls. So you can include only controls that are time constant. That would be things such as gender, because you cannot include time varying factors because that might bias the results. Okay, and it's important to note that using an interrupted time series estimator is also subject to bias associated with estimating linear and logistic regressions. So such things as serial autocorrelation. So that means the error term for the previous period is correlated with the error term for the current period. And then we have such things as well as omitted variable bias. That is when there's factors in your error term that are correlated with the coefficients in your estimator. That is why, as in this slide, we say that we can't include time varying variables, because we include the time constant ones, We can't include the time varying because we cannot be sure that we have fully controlled for omitted variable bias. With the time constant ones, we can basically control for that by including fixed effects, which kind of removes them from the model. Okay, so then to be sure that your model is correctly specified, as with any model specification, it is good to conduct some form of sensitivity analysis to test a range of model assumptions, such as similar to what we discussed with the difference in difference, so including lags or employing methods to control for potential bias from such factors as serial autocorrelation. So that would be controlling for random effects. Or as I said, you can possibly do some proxy fixed effect specifications to look for omitted variable bias. Okay, so then if you think that your data is suitable to estimate an interrupted time series, the first thing to do would be to plot your data points on a graph. And so this is an example using hypothetical data of time series data for dental caries in children. Okay, so if, say you were interested in looking at how dental care, how the introduction of a sugar-sweetened beverage tax reduced the number of dental caries in 7 to 10-year-old children. So, and the policy would be implemented. In this case, the sugar-sweetened beverage tax in the UK came into force in April 2018. So you have that blue line of the policy coming into force in mid-2018. Okay, so then you have the black circles on this graph are data points for number of caries in children, and each black data point, as it says, hypothetical data, just to be clear, represents thousands of children. So it's kind of mean dental caries across these children, and you can look at, and then the red line is the average time trend. So pretty much what you would be interested in when looking at this graph is the number of points above the red line and below the red line before and after the intervention. And what you'd want to look at is if there has been a change in the number of data points before, above and below the red line, before and after the intervention. Because if there is a change, then you can say that this may be an appropriate method to use for your estimator. Okay, so then the basic model specification is, in this case, we have our outcome variable is dental caries, which is DC, and that's a continuous variable for the number of dental caries. Then we have beta 0, which is the intercept or constant. So that is, because this is a linear regression, that's the mean number of dental caries for the sample population. There's no other control to the model. So that is a very quick way, if you were to estimate this, to check that the model is correctly specified. Because if you were to look at the mean number of dental caries in your data when you were estimating summary statistics, and then you were to do a simple linear regression, the mean shouldn't be that far off the mean that you find in the raw data. So the constant or intercept should be similar to that. And if it's very far off using a linear regression, then it's likely that your data might be misspecified, that your model might be misspecified. And then moving on, we have beta 1, and that's a baseline trend in dental caries in children. So that is, looking at this, the trend in dental caries if there was no sugar-sweetened beverage tax. So what you'd expect the average number of dental caries to be in 7 to 10-year-old children. They had not introduced the sugar-sweetened beverage tax. And X pre is a vector containing child characteristics such as socioeconomic status, sugar consumption. This captures the trend in dental caries before the introduction of sugar tax. And then X post is child characteristics after the introduction of the sugar tax. And then epsilon IT is a random error term. And okay, as I mentioned, looking at the intercept is a good way to get a sense check if the regression model is specified. And the other thing to keep in mind is that when you're entering a regression equation in a statistical software package, this also applies to using difference in difference. You need to make sure that the package knows that you're using longitudinal data, because otherwise it might not realize that there is a pre and post study period, and your model will be misspecified because it would think that everything was happening at the same time. You need to make sure that that is clearly divided by pre and post policy period. Okay, so then going back, if we were to estimate this model using hypothetical data, these would potentially be some results that we get. So we have an intercept of 0.98. So what this means is that the mean number of dental caries in children between 7 and 10 years old is just under 1 dental carie. And the confidence interval in this case is not 0.23, so not 0.89. So that would suggest, since it doesn't pass through 1, that it would be statistically significant. And the baseline trend, so that is before the introduction of the sugar tax, we have the mean number of dental caries is 1.27. And so that would suggest that before the introduction of sugar tax, that we'd expect the mean trend is for each child to have slightly over 1 dental carie. But then after the introduction of sugar tax, we find that the mean trend is not 0.67. So that is a significant decrease in the mean number of dental caries per children. And then that, as you can see, the 0.98 is kind of the mean in between those, so the overall trend over time. Okay, so then from this, we can say that if these were your results, you could say that the introduction of the sugar-sweetened beverage tax had a significant impact on decreasing the number of dental caries in children between the ages of 7 and 10. Okay, so then to summarize what we've been covering in this seminar is we covered 2 methods to retrospectively evaluate public health intervention policy using before-after study designs. And we discussed some of the model assumptions and how this might impact on causal interpretation, and some different methods we can use to check to make sure that we're estimating the impact of the intervention on the health outcome and behavior that we were interested in. And here are some of the references that were mentioned in the text. And then this is also, I've written a book recently on different policy evaluation methods for public health. And the examples used in this seminar are in the book, as well as covering some different methods if you're interested in reading more about it. And that is it for me. So now I'm happy to take any questions that anyone might have.
Excellent. Thank you very much, Heather. That was terrific. We haven't had a flurry of questions, so we might just encourage people now to use their Q&A tab at the bottom of their screen to ask any questions whatsoever. Just while they're coming through, Heather, I might ask a couple. I haven't used this approach in my research, but have certainly attended many presentations, both for difference in difference models and interrupted time series. So thinking about the pre and post design and the difference in difference models, I had a couple of questions. They're pretty basic questions as someone who doesn't use this technique. You mentioned at one point in time that this approach can be used for small sample sizes or modest sample sizes. And I just wonder if you've got any gauge or idea in terms of you know, numbers or what we might need to test for the ability to use this in small sample size?
So the basic simple rule of thumb would be to use a central limit theorem. So it would be n equals 30 really for grapes.
Okay.
I'd say would be the smallest that you'd want to try it with.
All right, terrific. And my other question was about the assumptions in for difference in difference models in order to, you know, estimate the counterfactual. So I wondered whether you could expand a little bit about the parallel trend assumption, because one of the applications where I had thought this approach might be really useful, it's unlikely that there would be a parallel trend post policy intervention, but rather perhaps a plateauing or a flattening off effect. And I just wondered whether you could describe a little bit more about how you assess for violations of that particular assumption.
Okay, so it is quite a difficult one. I guess really how it tends to be done, at least in my experience, is that you tend to look kind of focused on the pre-period. So if you could see a parallel trend in your outcome variable in this pre-period, and you can test it looking at, as I mentioned, different lengths of time pre-periods, then you can say that your treatment and control group are relatively well specified, because it would be difficult then to do to look at post-treatment trends, because it'd be hard to isolate if it was necessarily a change in trends because of the intervention or something else.
Yeah.
And it would just be something that you'd want to discuss when writing up your findings of, you know, that after this intervention, things might have changed between the treatment and control group, which might impact on what we found and what that means for interpreting your results.
Okay, terrific. No, that's very helpful. Okay, so we have 5 questions at the moment. I'll just start here from Alison Pierce. When you say the results from the ITS show the difference in dental caries between pre and post policy was significant, are you using a statistical test to determine significance, or are you basing that on clinical significance?
I was using a statistical test, so it was just looking at the confidence intervals. So I guess that's another thing to keep in mind, because there's statistical significance and then there's clinically significant differences. So that would be important when interpreting the findings, because it might be statistically significant, but it might not be clinically significant.
Okay, terrific, thanks. The next one, from an anonymous attendee, what's the difference between ITS and regression discontinuity design?
Okay, that is a good question. So interrupted time series, in a sense, is a slightly more flexible regression discontinuity design. So regression discontinuity design is stricter in the assumptions based upon the change in trends pre and post intervention. So with the regression discontinuity approach, you need to have pretty much at the time of the intervention a very clear kind of interrupted change in the trends. Where the interrupted time series is a bit more flexible of how the pre and post change in trends. I hope that makes sense.
Yeah, no, that's a great definition, description. Thank you. Next question from Maria Batista. Instead of looking at policy effects, if one were interested in implementation effects, time and location would probably be sources of differences, in addition to different administration of implementation. So the question is, could that stand well for difference in difference models? And then there's a comment, I noticed that these would be sources of your robustness checks, but if you were to use time and location as sources of differences, how would one check for robustness? There's quite a lot in there. Just if you want me to repeat any of that or pick out the general principle in terms of implementation effects rather than assessing policy effects.
So I guess it's sort of how you look at fidelity, isn't it, in a sense? If fidelity impacted on the change in behavior.
And a question about robustness. If you're using time and location as your sources, what might you be using for robustness checks?
See, in a sense, I would say that this is potentially why you need mixed method studies, because you need to have some sort of qualitative evidence on fidelity and how, you know, the implementation of the intervention may have been different in different locations, which I think would then impact on, once you knew kind of that, then that would affect how you did the quantitative analysis. So if you thought that there was differences in how people implemented the findings, then that would, I would say you would need to do some sort of clustering in your analysis to account for kind of differences in how the intervention was implemented, impacting on the health outcome.
Yeah, okay. That sounds good to me. The next question is from Louisa Gordon. Is there a minimum number of time points or measures collected pre and post? And do these need to be equal pre and post?
They don't need to be equal. And I guess the minimum would be one time period pre and one time period post, but that'd be the absolute minimum. And then there'd also be the caveat, as that I've mentioned, is that if that was the case, you could not test for some of the things such as anticipation effects of the intervention, or as well to look at kind of any lags in the effect of the intervention.
Okay, good, thank you. Our final question from the online participants is from Zhang Xiaoquan, and that's about further training in this area. Are there any short courses that you recommend or any tutorials, anything that listeners could attend or utilise, other than, of course, your fabulous book?
Well, I mean, there's quite a few short courses that I know of in the UK that are offered as well. I'm trying to think if there's any more.
You can mention those. Quite a lot of people from Australia visit the UK regularly for different reasons, and certainly attend training. So if there's any that you could recommend in the UK, we'd be quite keen to.
Well, I did one that we've offered in February, and we're going to offer again probably next October. They offer one in Oxford, and then as well, Manchester University has one as well as part of his summer school. And I don't know if there's anything, because I say IHEA sometimes has similar type things associated with the conference. I know they did the one in Boston, but I don't know if there's anything at Basel. And do you know who was running the course in Boston? I mean, we can certainly find out if that's going to be offered and send that round to the participants, or any other lecturers other than yourself who typically run these courses. Look out for. I can look. I don't know off the top of my head. I can look it up and I can send it to you.
Okay. Oh no, that'd be terrific. All right, are there any further final questions? Okay, that looks like we're completed. Oh, hang on, there's one in the chat box. No, that was asked through Q&A as well. All right, well, Heather, I'd like to say thank you very much for your content and expertise. This has been a really interesting introduction to two different approaches, and I'm sure will be a lot of food for thought for those of us who haven't routinely used them, but also, you know, help and support those who have used both interrupted time series and difference in difference approaches. So I'd like to thank you once again, and look forward to seeing you at other events. And thank you very much for making yourself available for.
Thank you very much, everyone. And if you do have any questions, I was going to say, I think my email's at the start. Let me see if I can find it. Please feel free, anyone, to send me an email. Thank you, everyone.
Terrific. Okay. Thanks very much.